I also included the underwriting customer service phone numbers. If you have not seen the information on our website, or if you've seen it and still have questions about policy documents, premium processing, coverage for certain practices within medicine, um, and also what can you do if you're having financial difficulty and you're not able to pay your premium right now. These are the phone numbers and the professionals excuse me, ready to help you. Over the last 6 weeks, the risk management hotline has exploded. So along with all of the information that you're getting about CMS waivers and guidance for surveyors, HIPAA, executive orders, all of that information, and then the deluge of phone calls from your patients who don't know what to do, we've been experiencing it right along with you. The difference is we are sitting safely behind a desk or a computer with hand sanitizer and at least 12 feet, if not more, between us and the next person. And you are in there providing these services, sometimes face-to-face and hands-on, often without the right equipment and supplies. So along with the initial rush of phone calls were questions about telemedicine. I would say for the first 2 to 3 weeks of the pandemic, as we know it in Arizona, the majority of the questions we were getting were from practices who had not ever used telemedicine, may not have even had the feature on their EMR or the capacity through a device or an application, needing to suddenly, overnight, convert to telemedicine. Those calls have decreased, and later Jeremy will share with you how those calls have transitioned and our answers to those calls. Calls that we're receiving now still have to do with HIPAA, and something to maybe remind everybody of is that HIPAA has an Office of Civil Rights. And so when we are talking about a patient's protected information under HIPAA, we are talking about their civil rights. And so HIPAA is extremely influential and difficult to comply with, and comes with some serious sanctions for non-compliance. And I wanted to touch on a couple of things about HIPAA. I also wanted to cover a few things that have come out from Centers for Medicare and Medicaid, CMS. We get a lot of calls from practices who say, CMS says I can take care of patients in Utah from my home office here in Arizona. And we have to explain, no, that's actually not what CMS is saying. CMS is talking about what they'll pay you for, but not necessarily what you're licensed to do. So I wanted to go over a couple of those things from CMS. I also wanted to talk about a recent executive order issued in Arizona that offers immunity for physicians and other healthcare professionals, but there are some criteria, and I thought we would go over that and hopefully take your questions and answers. So let's start first with HIPAA. We are still getting phone calls from practices who say, We've been having telephone appointments. Now we'd like to do something with video. What can we use? What can't we use? Or we have some practices who say, we started out using Zoom, but we're unhappy. What can we switch to? And the first thing we usually explain is that the Office of Civil Rights issued a notification of enforcement discretion. And the notification of enforcement discretion is not really addressed to physicians and other covered healthcare professionals. It's actually addressed to the OCR investigators. And it tells those OCR investigators that physicians and other healthcare professionals covered by HIPAA are not going to be subject to penalties for violations of the HIPAA privacy, security, or breach notification rules, as long as they are providing telehealth during COVID-19 in good faith. So sometimes when we are unhappy with the direction OCR gives us on HIPAA, it's helpful to remember that their guidance isn't necessarily always for the physicians and the other covered healthcare professionals. Their guidance is for their investigators. But this is good news for physicians and practices in Arizona, because prior to this notice to the investigators, the devices and applications for telehealth were fairly limited. And what OCR is saying now is that physicians and other healthcare professionals covered by HIPAA can use public-facing remote, communication products. Can use non-public-facing remote communication products. Now, if you're like me, the first time I read that, I didn't know what it meant. So I needed some examples, and OCR did provide some. Apple FaceTime, Facebook Messenger video chats, Google Hangouts video, WhatsApp video chats, Zoom, Skype, Jabber, Facebook Messenger, Google Hangouts, WhatsApp, iMessage, and Signal. So right now, until OCR notifies us that it's no longer exercising this enforcement discretion related to the pandemic, physicians and practices can feel fairly safe using these applications and programs to conduct visits and appointments with their patients. But we have to look back and be careful with the wording of the enforcement discretion notice. It says provision of telehealth during the pandemic in good faith. Now, they did give us some examples of bad faith, things they're going to look at that they might consider bad faith. And one of them is using public-facing remote communication products, and they list several: TikTok, Facebook Live, Twitch, and other public chat rooms. So those were not acceptable before the pandemic, and they're still not acceptable. And, you know, a reminder, right now, this is temporary. I guess I'm being hopeful that this pandemic will end, and we will live in a world that is partly the things we've traditionally done and liked, and partly new things that will be better for all of us. I don't know if OCR will permanently relax their enforcement discretion. But for now, if you're using Facebook or Zoom, still keep in mind that this could end and you may have to find another program or application where you can get a business associate agreement and that OCR will look upon favorably. While we were talking about federal enforcement, I wanted to bring up the Department of Justice Drug Enforcement Administration, the DEA. And this is important for those of you who have licenses to prescribe controlled substances. Our governor issued executive orders that loosened some of the prescribing restrictions related to physical examinations. And that is great if you're prescribing something that's not a controlled substance. If you're a DEA licensee, you also have to check and see what does the DEA say about this. And what the DEA has said is for the duration of the public health emergency, unless they specify earlier, if a physician or other prescriber has not previously examined a patient, they must evaluate the patient using in-person, real or real-time two-way audio-video communication. And so that means a telephone call is not going to be sufficient should the DEA look into a prescription for a controlled substance. They're still either going to want to see an in-person evaluation or a real-time two-way audio video communication. So next I wanted to talk about some of the CMS waivers. I wanted to share with you that when I was putting my summary together and I was looking for great resources, I found one and I used it, and it was smack dab on the ArMA website. It was the ArMA COVID-19 telemedicine guidance for Arizona physicians dated this month. And I was able to download it from the website. And as an outsider looking in, it seemed to have a lot of good information on reimbursement, questions to consider, things to document. And if it's a document you haven't downloaded, I highly recommend that you download it and that your office staff uses it. One of the CMS waivers I wanted to talk about was actually something that they published in February, information for healthcare facilities concerning the 2019 novel coronavirus. And even though it says information for healthcare facilities, it's written as a reminder to the CMS surveyors that they're supposed to be monitoring and watching out for the same infection control and prevention standards that they were supposed to be looking for before the pandemic. And I point this one out just as another example of sometimes we look to these things as guidance for ourselves when in fact it's guidance for their investigators and surveyors. The last thing I wanted to cover was the Arizona executive order issued April 9th called the Good Samaritan Order. And I know that ArMA represented physicians in trying to get this kind of order passed. And when you look at the language, you can see their influence. And what the order says is physicians, surgeons, nurses, osteopathic physicians, osteopathic surgeons, pharmacists, physician assistants, and respiratory care practitioners, or volunteer health professionals registered and recruited through the Arizona Emergency System for Advanced Registration of Volunteer Health Professionals. So there's two groups that are protected by this. And it protects those who, in the course of providing medical services, by presuming they acted in good faith and therefore are immune from civil liability. It's very exciting to hear this, but I do want to share with the audience that in most states, these grants of immunity, whether statutory or by executive order, have not been tested. And the statutory Good Samaritan Act in Arizona has not been tested, I believe, at the appellate or Supreme Court level. And so while we believe that this will protect our physicians and surgeons, we do have to wait and see and watch a case and see what the judge or the jury decides to do with it. So at MICA, we're happy to see this language, but we recommend you not drop your liability coverage. We'd like to see it tested before you do something like that. And this order is in effect till June 30th unless it's extended. So HIPAA, some of the CMS waivers, some of the federal issues, and the Arizona executive order attaching immunity from liability. I don't know if any of you have questions, especially about the new executive order.
Great. Thank you, Karen. Were you wanting to open up questions to this, or did you want to continue with your next slide about preparing for practice post-COVID-19? Or would you like me to go ahead and open up for questions now at this point?
Well, I think this would be a great place if Dr. Goldberg had anything else he wanted to say on the new order. Within a matter of the last 2 hours, that greatly affected what Micah was going to say about preparing for practice post-COVID-19. So I was just going to give you a chance first before we opened for questions.
Appreciate it, and thank you for reviewing all of that, actually. I don't want to take too much time. We have experts on the panel for a reason. We were involved in providing some input and guidance and guardrails on how to ramp this back up, which I was happy to see in the order that they showed up. The language looked awfully familiar for a reason. That the idea of testing everyone beforehand, having adequate PPEs, having a process in place is important. I do know we're getting some questions on some of the other stuff you were talking about, which is why I'd rather pivot back to that. I think I'm asking the audience to give us a little more than the 2 hours we've had to digest the order that came out so that we can appropriately advise everyone. But there'll be more information coming tonight and tomorrow and after that, how it's going to happen. Trust me, because we've been kind of waiting for this for a while. That's all I got.
Great. Thank you, Dr. Goldberg. I appreciate that. I just want to remind everybody real quick before we get, I see there's some questions that have been sent to us via the webinar chat. There is a Q&A button at the bottom of your screen. if you wouldn't mind, we'll answer the questions that have been sent via chat, but any future questions, go ahead and start to submit them through the Q&A. Just remember that we cannot hear you or see you, but you can hear and see us. So if you would mind, go ahead and start asking your questions through there. Looks like we have one question that was asked during your presentation, Karen, to just some clarification on what public facing means and how not some apps are subject to enforcement and other public facing platforms are not. Karen, you're still on mute, just so you know there.
And what I said was confusing because when I started, I initially mixed up the two. So thank you for giving me the chance to clear that up. I guess in my non-information technology professional interpretation of what OCR is saying, the public-facing apps are easier to hack, and the public-facing apps are TikTok, Facebook Live, and Twitch. And because they're in essence, easiest to hack, they have never been acceptable under HIPAA and are still not during the pandemic. Non-public facing apps are less likely to be hacked. Now, we all learned in the national news that Zoom has been hacked multiple times. And so none of this is foolproof. But the non-public facing apps are harder to hack. They were iffy before the pandemic. They're acceptable during the pandemic. Those are Apple FaceTime, Facebook Messenger, Google Hangouts, WhatsApp, Zoom, Skype, Jabber, iMessage, and Signal. We know these are acceptable during the pandemic. What we don't know is if OCR if these will fall out of favor with OCR after the pandemic. We just have to wait and see what OCR says. But during the pandemic, if you're going to use a non-public facing, least likely to be hacked app, it would be one of these: Apple FaceTime, Facebook Messenger, Google Hangouts, WhatsApp, Zoom, Skype, Jabber, Facebook Messenger, Google Hangouts, iMessage, and Signal. So I hope that helps. Jeremy, do you have anything you want to add?
Yes, I do, Karen. I think, taking it back to its basics, it's anything that's public facing is something that's in the public domain. So Dr. Goldberg couldn't, on his private Facebook page or on the ArMA Facebook page, have a private consultation with a patient and give them medical advice. It's something that's just basically there. It's in the public domain. So I think it's as simple as that. The non-public facing are indeed that. It's the one-on-one where a login is required or somebody is required to do that. So.
Thanks.
Karen and Jeremy, this is Libby McDaniel. I have a question. Karen, you had referenced the hotline that Micah has and that you've gotten some interesting questions through that hotline. Can you or Jeremy expound a little bit on that and talk about how you're handling those questions and what some of them might be for the attendees?
Yeah, I can. I think one of the ones, as Karen mentioned, we had an absolute explosion of phone calls about 3 weeks ago about telemedicine, and we took easily over 200 calls from our policy holders. A lot were basically inquiring, we've never done it before, and this is our sort of first opportunity to do it, which was great. Fantastic opportunity. There's a couple of things I just wanted to put into those. And it's to do with practicing now, but it's also to do with practicing in the future as well, I believe. But one of the things with telemedicine, as Karen mentioned, we have all the HIPAA issues and the HIPAA waivers and PHI. But I think some things that people hopefully don't forget, there's obviously consent aspect to telemedicine as there is telehealth, as there is to anywhere else. And we've provided some advice. As you know, I'm just made some notes. ARS 36-3602 subsection A states that except as provided in subsection E of this section, before healthcare provider delivers healthcare through telemedicine, the treating healthcare provider shall obtain verbal or written consent, informed consent from the patient or the patient's healthcare decision maker. If the informed consent is obtained verbally, the healthcare provider shall document the consent on the patient's medical record. I think this is important because a lot of providers are out there, physicians and providers are out there thinking, well, can I scan the consent? Can I get them to sign it and scan it back? And well, obviously that's not that important. What is important, what we always say in MICA is probably of at most important, probably jointly as important as get somebody to sign something, is the quality of the conversation that the physician, the provider has with that patient about the risks, benefits, analysis, and alternatives of the treatment, of the assessment and the treatment. So very much important. That quality is great. And obviously then the subsequent documentation of those issues in the medical record. So if there is verbal consent, especially, it's got to be done. But yeah, paramount. And I think just a couple of things we've sort of suggested within a consent domain to sort of discuss with the patient with telemedicine is obviously the possible risks of telephone, telemedicine, telehealth visits, whether it's audio, visual, audio, whatever. There's a risk of insufficient transmission of an image or data. There's delays in diagnosis or treatment related to equipment problems or failures. And obviously there is that breach of confidentiality, even though the waivers are there. CMS especially are advised to providers to tell patients, to notify patients that these third-party applications potentially introduce privacy risks. And providers should enable all available encryption and privacy modes when using such applications. So even though there's the waivers, hey, still got to balance that out with patient safety. We also suggest the possible benefits include improved patient access to medical care, decreased risk of any spreading or encountering of infection, disease, conditions or disease, especially in this current climate. Possible alternatives, which may include conducting the visit in person or through another telemedicine technology when medically indicated. The patients obviously have a right to inspect any information documented during the visit. The physician or healthcare professional does not guarantee or assure a specific outcome or result of the telemedicine visit. Patient or patient's representative authorizes and consents to the use, actually, as we discussed. The patient or patient's representative may withhold or withdraw consent to any telemedicine consult as well. And obviously, documentation of the date of the patient's signature, if applicable, or the date of verbal consent is important. In Arizona, the informed consent doesn't apply in emergencies where the patient or patient's representative is unable to consent to the service. The patient is not physically present, as we say, with a verbal consent issue, which is good. The physician or the healthcare professional transmits images to another physician or healthcare professional and serving as a consultant. And the consultant physician is reporting to the treating physician or healthcare professional the imaging results. So those are things that we sort of encourage our policyholders to still go over, even though things have changed so much with telehealth. Another thing that I just wanted to quickly cover as well, which is something that goes hand in hand with the telemedicine. It is sort of separate as well, but these are the calls we're getting. We get lots of calls from policyholders, especially with snowbirds, asking about patients that are temporarily in another state, or physicians from another state are contacting the patients in this state, in Arizona, and actually talking to them. The issue is for instance, can a prescription be refilled for a patient in another state? So Dr. Goldberg has a patient in Arkansas, they're there visiting, I know, bear with me, and they require a prescription refill, maybe a post-op issue, whatever. So obviously with the the recent headline from some weeks ago that physicians have complete freedom to practice across state lines. It has sort of caused a few alarm bells, shall we say. And I think just going back to the beginning, practicing medicine across state lines is always tricky, regardless of the current crisis or not. And yet the Federation of State Medical Boards state that the practice of medicine across state lines is defined to include any medical act that occurs when the patient is physically located within the state and the physician is located outside of that state. Any contact that results in a written or documented medical opinion that affects the diagnosis or treatment of patient constitutes the practice of medicine. So as you say, we saw this headline a few weeks ago, and we were concerned that people would just go off and start practicing. So the advice we're giving is that it is complicated. It's not straightforward. We don't know every state and what they are demanding for license waivers or for temporary licenses or things like that. So we're suggesting to everybody that calls us that they actually get in touch with the state that they intend to practice in to find out what their requirements actually are. We can't go into the specific states, but obviously it's good from there. Obviously the next step as well is to check your malpractice insurance carrier, as it may not be completely obvious that that carrier may not geographically cover you for malpractice insurance in the state that you wish to practice in. So for instance, MICA covers Arizona, Utah, Colorado, and Nevada, but not other states. So I'm moving into the future, and perhaps telemedicine will remain as popular. Something that obviously we also have been in the past and we will do in the future is suggest is the Interstate Medical License Compact as well, is something that is there for physicians and other providers to actually try and access and apply for, which then allows them, I think it's 29 states they can practice in up to there. But again, what's all important is that they can check that with their malpractice carrier, and also that they keep on checking with the various medical boards in the states that they wish to practice in, because as you know, practice rules differ so much between boards that it's important to get on top of those to make sure that you are sort of complying with the regulations and everything else. I think those are the two main things without spending too much time. But thank you.
Thank you, Jeremy. Actually, that answers one of our questions from one of the attendees tonight, the last bit there. So thank you for including that part. There's another question that was submitted a little earlier ago, asking how about retired physicians that want to come back without reestablishing malpractice? Does the Good Samaritan protection on its face extend to volunteers doing more than directly treating COVID-19, such as providing mental health services?
I'd like to look at those in two parts. First, the retired doctor wanting to come back without malpractice insurance. I am not sure I am the most objective person to answer your question because I work for a professional liability carrier. And as a carrier representative, I'm not sure that this immunity will hold up and protect a retired physician or an actively practicing physician. And I would not want a physician to be caught without coverage should they be sued. Here's another thought too. Anybody with a $20 filing fee and a ride to the courthouse can file a lawsuit. So this does not prevent someone from filing a lawsuit. It still means someone can go to the courthouse, file that lawsuit, serve you with a summons and complaint, and you may be well into the process of interrogatories and depositions before there's a hearing where someone says, Your Honor, immunity attaches, we want this dismissed. So there are costs associated with having a lawyer to help you respond to that summons and complaint. And in Arizona, you've got to respond to that summons quickly. There are costs associated with answering those requests for interrogatories and testifying in a deposition. And if you didn't have malpractice insurance, I guess you might have to cover some of those costs yourself. And I guess that would be a personal financial decision. So you may want to talk maybe to your ArMA representatives or to your personal counsel to get the most objective opinion on the Good Samaritan protection extending to volunteers. The executive order applies to physicians, surgeons, nurses, osteopathic physicians, osteopathic surgeons, pharmacists, physician's assistants, and respiratory care practitioners. It also applies to volunteers registered through the Arizona Emergency System for the advanced registration of volunteer health professionals. So you would have to be a volunteer through that system, or you would have to be one of the named licensed healthcare providers. And the immunity attaches to the provision of medical services. Medical services is not further defined by the executive order, but for instance, if you're a physician, medical services are addressed in the Arizona Code, the Arizona statutes. So if you're a physician volunteering and providing maybe mental health services, I would think that this executive order applies to you. If you are another kind of healthcare professional, such as a licensed counselor in social work, or a licensed psychologist, and you're not part of the Arizona Emergency System registration, I don't know that this executive order applies. If you are a licensed healthcare professional or an unlicensed healthcare professional not named in this executive order, you may want to talk to personal counsel about your risk and whether the act would cover you. If the act does cover you, you can still be sued, and you might still need representation, and you might still need assistance with defense costs. And I don't know if anybody, ArMA, Jeremy, want to add to that.
That seems like a good overview. Thank you so much for providing that. I think we also want to leave a little bit of time at the end of the webinar for any other questions, whether they're liability related or not, related to COVID-19. So if you have any questions for any of the panelists, please feel free to put them into the Q&A.
Yes, thank you, Libby. There was actually a question that was submitted prior to tonight that I wanted to bring up, and start off with mentioning the appreciation for the concerns for viability of physician-owned and managed practices and the need to support staff payroll during the pandemic. It's a very important role for ArMA, and our colleagues definitely need the support. Could you comment on the issues that employed physicians are having with decreased work hours and possibility of furloughs and layoffs, especially concerning for emergency medicine and anesthesia physicians employed by practices here in the Valley? Dr. Goldberg, would you like to comment on that?
Sure, and I can speak as an employed physician, actually. I am a member of District Medical Group, which is a large physician-owned practice, which we're contracted to provide all the care at Valley-Wise Health. So I get it. I understand. I will say on one hand, employees are employees, and just like we have certain physicians that own their own practices and have employees of their own that they're having to figure out what to do with the financial constraints, these larger employers are having the same problem. We're aware of it. We are trying everything we can to try to get finances to not just the private practices, but to those groups as well, because everyone kind of needs financial support. Doing that through requests at the state and federal level, talking with the governor's office, looking at the CARES Act. I know COVID-4 is currently being constructed, so trust me when I say is that I'm trying to reach out to people out in DC and where we can have influence. Also, we have a call with the insurance companies on Friday to talk about kind of the telemedicine stuff, and again, looking at those reimbursements. So we are trying to be very creative and to find ways to get funds to those organizations in a time when we're not doing as much, but it's not anyone's fault we have lower volumes. It is a virus mandated lower volumes, so we can't be penalized for something we have no control over. So we are working very hard on that. It is not perfect. It is far from done. It won't be done when the pandemic lifts because there'll be the residual effect that we'll have to address. But we are aware of it, and we are continuing to come at it from whichever which ways we can, involving whichever stakeholders we can. That I can promise you.
Great, thank you, Dr. Goldberg. Appreciate that. Let's see, there's another question here. If ArMA is aware of the rate limiting factors to increasing testing in Arizona.
Yeah, supplies.
Libby or okay.
Libby and I are on the phone with DHS yesterday. I forget what day it is anymore. And if you've watched the news, every state, it's amazing. It's like they all just are reading from the same script. It's a supply issue. And it's a moving supply issue, right? It's the test one day, it's the reagent the next day, it's a swab the day after that. We just need to make more of it. And the hope is that the market catches up. I don't know how fast it can. Interesting, I think they're saying, they're quoting that we need to be doing 4 to 5 million tests a day. We're not there yet. So that's a rate limiting step, is that it's just supplies. So it's amazing how we're shifting from PPEs to testing. We keep on bouncing back and forth like a ping pong, but the theme of both is that we don't have enough of either. And the question is, where are we getting them from? And we can't make them fast enough. The federal government's aware of this too. It's not like a big surprise. And depending on what day of the week, you'll hear different stories of it's the state's problem or it's the federal government's problem, but they also exhaust a lot of their supply as well. So we have to be smart with how we do this and just try to get more if we can, but a rate limiting step is just supplies. And, unless someone on here wants to start building them yourselves and, maybe we could talk offline about a business venture here to kind of build more supplies. I don't know what else honestly to say, is that we just need to keep on asking for it and hope more will be produced.
I'll just add to that. I think that's a great answer, Dr. Goldberg. And honestly, that's the rate limiting factor in being able to move forward and opening up the economy. We know that we really need widespread testing to better understand what the risks are and to protect our healthcare workforce as well as the public health of all Arizonans. And so we're continuing to advocate for the supplies related to testing as well as the PPE equipment. But that it really is the rate limiting factor right now on opening up the economy.
Great, thank you both. There's one other question here. I think we'll kind of close off with this one. I believe that, Karen, you might have covered this a little bit regarding the settling in court, or we're not going to really know until it does go to court. But there's a question, if the governor's mandate about the Good Samaritan protection isn't strong enough, what exactly should be done? And I believe you kind of touched a little bit on that in the beginning of your talk. Did you want to add anything to this question? And just a reminder, you're on mute real quick there.
I need a Post-it note right here. You're muted. If this was legislated as opposed to being part of an executive order, there would still be a constitutional challenge. Is the language in the statute protected and representative of the intent and language of the Arizona Constitution? And generally, you will see a constitutional challenge with new legislation. We would hope just like we hope the executive order withstands a legal challenge, we would hope that legislation would withstand. So no guarantee there, but I will share that several other states have legislated their Good Samaritan language specific to the pandemic.
I just have a quick question off that. Karen, isn't it true though, because we had this discussion internally, our state constitution kind of throws up a lot of barriers as well regarding medical liability, which makes the governor's ability to do things quite limited anyway. Isn't that true?
Yes. Yes.
I don't remember if we talked about it, so I wanted to throw it out there for our audience to remember that. Unfortunately, we're not like other states where we can have a free-for-all.
Exactly. But there's good in that too.
Do not disagree.
Thank you, Karen, for that response there. So that'll wrap us up this evening. If any questions come up regarding tonight's town hall topic or anything else for that matter, we've got our email address here, communications@azmed.org. Feel free to send that over to us. We'll filter it to the appropriate department here within ArMA, or send it off to Karen and Jeremy over at MICA to help better answer some of these questions that may come in. Just a quick reminder that the town hall was recorded, and we promise we will have it up a little quicker than we did from last week's, up for your viewing and used as a resource for the coming months going forward. And then just a quick reminder as well that ArMA is here for you, for the physician community. So we have plenty of resources available on our website, from telemedicine to financial, the frequently asked questions page, as well as a downloadable free telemedicine guide. So thank you all for joining us this evening. I'm not sure if Libby or Dr. Goldberg wanted to say anything more. I'll give you guys a second here. No?
No, I just reiterate our thanks to all of the attendees for your time. Our goal is to continue to do these, preferably on a weekly basis, and we'll continue to provide updates on the topic for future webinars.
Say good night, stay safe.
Great, thank you. Good night, everyone.
Good night.